Hey everyone, welcome. So today we're going to build a practical clinical toolkit for a condition you will absolutely see in your pharmacy, Raynaud's phenomenon. We're going to break down what it is, how to spot it, and most importantly, those key counseling points that'll help you make a real difference for your patients. Okay, let's just dive right in.
So here's our game plan. We'll start by painting the clinical picture. Then we'll put on our detective hats and do a little pharmacist investigation. After that, we'll talk about why lifestyle counseling is your #1 tool, then navigate the medication options. And finally, we'll touch on special populations, like when a patient is pregnant.
All right, let's kick things off with Section 1, the clinical picture. Before we can counsel a patient well, we really need to get a handle on what's physically happening when they tell you their fingers are changing colors in the cold.
So at its very core, Raynaud Phenomenon is basically an over-the-top reaction to cold or even stress. It's this really intense, abnormal vasoconstriction. Think of it like the small arteries in the fingers just clamping down way too hard. This is the fundamental mechanism you got to grasp to explain it simply to your patients.
The classic story you're going to hear from patients is this 3-phase color change. First, their fingers turn white. That's from the blood flow just stopping. Then, they turn blue because the blood that's trapped in there starts to lose its oxygen. And finally, when the blood flow rushes back in, they flush bright red. Now here's a really important clinical pearl. For patients with darker skin, this can be way harder to spot. You might need to suggest they look for paler fingertips or even check the palms of their hands.
Now, this is a crucial distinction for us as pharmacists, knowing the difference between primary and secondary Raynaud's. Primary is super common. It just happens on its own, and it's generally not a huge deal. But secondary, well, that's a red flag. It's being caused by something else, maybe an autoimmune disease like scleroderma, or, as we're about to see, a medication. This is where you can run into nasty complications like painful digital ulcers.
And that leads us directly to one of our most critical jobs, the medication review. So for our second section, let's dig into the common drug-induced causes you have to have on your radar.
Before you even start thinking about what to recommend for treatment, you have to ask this question. A really thorough med history is completely non-negotiable here. Because if you can find and stop an offending drug, that is by far the best intervention you can possibly make.
And here are your prime suspects. You really want to pay close attention to CNS stimulants. Think how common methylphenidate is. Also, keep an eye out for certain chemotherapy agents like bleomycin and cisplatin, and some of the older migraine meds like ergot derivatives. Anytime a patient comes in with new or worsening symptoms, you should be scanning their profile for these drugs.
Okay, so once you've ruled out any drug causes, it's time to move on to the real foundation of care. For Section 3, we're all about lifestyle counseling first, and I really can't say this enough. Your advice and your education are often going to be more powerful than any prescription we talk about.
This quote really says it all, doesn't it? Medications only work for, at best, about half of the people who try them. This is such a critical expectation to set with your patient. Your counseling isn't just some nice little add-on. It is the primary therapy. Reassuring them and educating them is absolutely essential.
So what do you actually tell them? Well, it's way more than just wear gloves. You need to counsel them to dress in layers, cover their head, their neck, because that helps prevent the body's natural reflex to clamp down blood vessels in the cold. Quitting smoking is huge. Nicotine is a powerful vasoconstrictor. And tell them to try and avoid things like vibrating power tools if that's part of their job or a hobby. These are the kinds of actionable tips that really empower the patient.
All right, for those patients who are still struggling despite making all those lifestyle changes, we can move on to Section 4, Navigating Pharmacotherapy. Let's walk through the medications in our toolkit, but let's start with some realistic expectations about what they can actually do.
Right, we're bringing this number back because it is just so important for managing the expectations. We're aiming to reduce how often and how bad the attacks are, not necessarily to make them disappear completely. We have to be honest that drug therapy is only successful for about 40 to 60% of patients.
So when we do decide to reach for a prescription pad, the dihydropyridine calcium channel blockers are going to be our go-to, our first-line agents. We're talking about familiar drugs here, like nifedipine, amlodipine, and felodipine. They work by helping to relax and open up those tiny blood vessels. Okay, this slide. This has a critical dosing pearl on it. Maybe the most important counseling point you can give for CCMBs. If the patient is using it as needed, they have to take it 30 to 60 minutes before they go out in the cold. It's all about prevention. Also, you got to prepare them for the common side effects. Some flushing, maybe a headache, some ankle swelling. Let them know these are expected and usually manageable, especially if they end up taking it every day during the winter and build up a tolerance. But of course, not everyone can take CCBs, and for some people they just don't work. So, what's next? What else do we have in our toolkit?
Well, we do have a few other options. Losartan is a totally reasonable alternative. You can also try topical nitroglycerin, which is applied right to the area. But just be aware, headaches and low blood pressure are super common with that one. And then for the really severe, tough cases, a specialist might consider a PDE5 inhibitor like sildenafil, but these are expensive and come with their own set of significant side effects.
And finally, let's tackle a really common and important scenario in Section 5, special populations. We're going to focus on a question you are almost guaranteed to get in your practice. What can we do to safely manage Raynaud's for a patient who's pregnant or breastfeeding?
The very first thing you should know and tell your patient is that for most people, the symptoms actually get a lot better during pregnancy. All that increased blood volume and the hormonal changes are kind of protective. So usually those non-drug measures we talked about are all they're going to need. And that's a very reassuring thing to be able to share. But if the symptoms are really severe, especially with secondary Raynaud's, nifedipine is considered the drug of choice. It's safe to use in both pregnancy and breastfeeding. The key takeaway here is consistency. If medication is an absolute must, nifedipine is your go-to.
So let's wrap this all up and summarize our clinical toolkit. Number 1, lifestyle counseling is king. Always start there. 2, always check for drug-induced causes. 3, your dihydropyridine CCBs are first line. 4, the most important counseling point is timing that dose before cold exposure. And 5, nifedipine is your safe choice for patients who are pregnant or breastfeeding.
And that kind of leaves us with one last thing to think about. Considering that the medications have pretty limited effectiveness, what is truly our most impactful intervention? Is it the product we dispense, or is it the information we explain? The evidence really suggests that our role as an educator, as a counselor, that's where we can provide the absolute most value for our patients dealing with Raynaud phenomenon. Thanks for listening.